Perfect. Okay, fabulous. Well, welcome everybody to our January Provider Spotlight on infant and early childhood mental health and mental health assessments for young children. We're going to get started with a little bit of background today of why we're here, what we're doing, and what we're going to learn about. So at the Healthcare Authority, we have a set of policies, sometimes we call it a program, that we refer to as mental health assessments for young children. We also have an acronym for it, which is MHAYC. So if you hear someone or myself say the word MHAYC today, we're probably not talking about the department store, probably talking about this program. The intention of these policies is to really support developmentally appropriate best practices for young children in that assessment or that diagnosis, intake, evaluation, lots of words for the same thing for really young kiddos, because often our behavioral health systems are set up more for older kids, youth, adults, and they might not take into consideration the unique, developmental and relational needs of young kids. And so these policies are really to align our Apple Health or our Medicaid system with what we know to be best practices. Most of these policies are around allowing additional things when it comes to reimbursement, so aligning payment with best practices. These aren't things that are required, these are just things that are allowed. And you might hear some of them referenced today. So they're around allowing for multiple sessions to conduct the assessment because working with young kiddos can take more time, and allowing provider travel to home and community settings so that these things can happen in natural settings where kids are most comfortable. The last piece is to require providers to use the DC 0 to 5, which you also will probably hear a little bit about today, which is really the developmentally appropriate diagnostic manual for this age group. This is a little bit of a visual to help folks understand how these pieces fit together. So if you haven't been through a DC 0 to 5 training, highly recommend. I know our training coordinator, Bridget, is actually here in the audience today, so she might be able to put a link in the chat to sign up for additional trainings. But the DC 0 to 5 is organized in different axes, which are really intended to make sure folks gather all the information that's needed to make a mental health diagnosis if that's what's happening for a young kiddo. Young kids have a lot of special developmental and relational needs, and so we want to make sure we understand the full picture before folks jump to a mental health diagnosis of a disorder, or not. Maybe there's not a disorder. It's also important to remember that this is all happening in the context of culture and community. So there may be things that, from our culture, how we grow up in our community feel developmentally appropriate, but that in a different culture, community are seen differently. And so when we think about the DC 0 to 5 and the assessments that we're doing, it's really important to take that into consideration as well. So with all these pieces that people are holding, it's hard to get that done in one session. Sometimes you might even have a 60-minute or a 90-minute session. And so that's really the intention behind allowing the multiple sessions, is for folks to gather this information in a good way. About, 2 summers ago, Christine and I went around to all the regions of the state and we met with infant and early childhood mental health providers to say, hey, how's this going? Like, we rolled out these policies, we had all these good intentions, did it work? And we talked to a lot of different people, we gathered a lot of information, and we had great support from a lot of different partners around the state. I think some of you who are in the room here were part of that. And one of the things we heard that it was really powerful to be together with other providers and hear what was going on. It's great when agencies like the Healthcare Authority can provide clear and consistent guidance, like that's an important responsibility. But it's also really helpful to hear from other providers who aren't necessarily trying to tell you like what the rules are or how things have to be, but just to spark ideas of what could be, and to support one another in thinking that like, okay, it's not always going to go perfectly. Sometimes we're going to hit roadblocks, but if we're in this together, we can move through those challenges. When we met with people, they elevated that, the DC 0 to 5 training is great. It's a great first step, but it's not all that's needed to really put this into practice. There's a lot of different pieces that agencies, organizations, providers need to do this in a good way. Some of them are on the screen here today. And so seeing all of this, what HCA was like, thinking we could do was to host these provider spotlights to really elevate how other providers like yourself are doing this in practice. You can see kind of where we are in the grand scheme of things. We've done 2 so far. Slides and recordings are on our webpage, and now we're here in January. So without further ado, it's now time for our provider spotlight. I'm going to stop sharing my screen, or I'm going to try to at least. Okay, and I'm going to do something else, which is to pin myself, and I can find Rosalinda. Oh, perfect. Okay, and we're going to get started with some introductions. So Megan and Rosalinda, a little bit of a long introduction, but could you each share with us your name and preferred pronouns, your organization and role, where your organization is located, like geographically or in terms of the population you serve, and how you got started working with the birth to 5 population. And let's start with Megan.
Okay, thank you. My name is Megan Huffman. I'm from Columbia Wellness here in Longview, and we serve Cowlitz County. We serve other counties as well, and we have a location in Grays Harbor that we are slowly integrating DC 0 to 5 into as well. I work with the child and family team, so I am primarily working with kids 0 to 21. And how I got started with DC 0 to 5 was actually I was the project director of a project launch grant that served children 0 to 8. And what we noticed was we know how to work with the 5 to 8-year-olds, but the 0 to 5 was something new to us because in Columbia Wellness, it's mostly just fee-for-service outpatient program. We have our WISE team who goes in the home and the community, but regularly we're just typically at the office. We're in some schools, but we're not really able to meet those younger kids where the needs are. We would have kids come in and a lot of times they would get turned away because there was nothing we could really diagnose them with when they're 2. It was more like a relational problem or parenting, things like that were identified. And so that's really where we started to look at what else can we do. And so we got connected with DC 0 to 5. I want to say like the first overview training ever was like during COVID. And then it sort of built from there. And we really focused on learning about DC 0 to 5, getting the clinical training. We were able to host some trainings and really work with like the early childhood and infant and early mental health. And that's kind of how we got started in this. What else am I missing?
I think that's good for now. Let's hear from Rosalinda. I'll come back to you, Megan. Don't you worry.
Hello, everyone. My name is Rosalinda Cummings, and my pronouns are she and her. I work at Hope Sparks, which is an organization that does a bunch of different things. I work within the early intervention office, Children's Developmental Services. We are located in Tacoma, Washington, and serve Pierce County. We're one of several early intervention agencies in Pierce County, so we serve parts of Pierce. And I believe so. I wasn't here when infant and early childhood mental health came to Hope Sparks, but the story that I've heard, or the way that I feel like this came about, was that Hope Sparks has always had a really strong investment or belief in the power of supporting young children and families. Like that's always been the mission and goal of the organization. And so we have the early intervention birth to 3 program. And then we've also historically had a behavioral health program serving children, youth, and families. So 0 to 18, 0 to 21, it kind of shifted a little bit over the years. And I think that the training and focus was primarily on some of those older kids, similar to what Megan was talking about. And so I think around 10 years ago, there was just a confluence of events and people at Hope Sparks where there were people in the behavioral health side who had had experience working with the really young children, and people on the early intervention side who were interested and excited about integrating more intentional mental health into their 0 to 3 work. And so they started working together. And I think that it was a big investment, I think, from the side of the organization. Like, my understanding is it wasn't particularly financially, like, I don't know, sustainable on its own right away. Took a few years of really just believing in the importance of this work to then be able to build a structure or program that worked financially and allowed us to invest in this work and supporting the rights of our youngest citizens. And I also, like, just briefly to speak of my own self. So I came to Hope Sparks because there was an infant and early childhood mental health program. I'm newer in this field. I've been, I think 2.5 years out of grad school at this point. And so still building all of that. But I came here because of this program. I have my own personal experiences with, like, really attuned caregiving. I had the most amazing mama who cared so much about who I was as a human being, and like making sure she was noticing me and feeling me and holding me. I should say my dad's amazing as well. But my mom burnt out and left when I was 5. And so there was a period of time where that attunement was just gone. And so I think I come to this work from the personal stance of, like, I know what it's like to be attuned to, and I know what it's like when caregivers aren't able to maintain that. And so I really want to be able to support families and young children in having those experiences of attunement and connection and safety, and then also supporting caregivers and having the sustainability and longevity to be able to maintain their role as parents and caregivers. And so I think it's phenomenal that we have this pretty robust at this point program for infant and early childhood mental health here at Hope Sparks. And I just want to keep growing it. We have been really focusing on 0 to 3 for a long time, and we're just dipping our toe in building a 3 to 6 program. And so I'll talk a little bit more about that, I'm sure. But it's a very large undertaking to kind of go outside of the comfort zone that we have established in the 0 to 3 framework.
Thank you both so much for sharing your background and your experiences. And I love what you brought up, Rosalinda, about the importance of that attuned caregiving. And I know that's something that I've heard Megan talk about as well, is that just the importance of the parent-child relationship and the work that we do. And I'm wondering, Megan, if what Rosalinda shared, this is a little bit off script, brought anything up for you in terms of what you see in the parent-child relationship and how you support that in your work.
Yeah, especially, we were really lucky to have this grant in which we could be able to dedicate some time in learning some of these things and taking the trainings for DC 0 to 5. And we were able to really focus in, like, PCIT and things like that too, and learn some other ways in which to enrich the parent-child relationship and dynamic. And so that was really helpful in also adding in another lens of what are we looking at here, seeing how we can help parents increase that, and being able to really support them on an outpatient level now too, with the DC 0 to 5 and the crosswalk, and being able to add that in for our young kids.
Thanks so much. I am doing a little bit behind the scenes, moving pieces around on our back end agenda. So thank you both for your flexibility. But the next question I wanted to ask was around community partnership. I think a lot of times in this infant mental health field, we think about the parallel process and how what happens with the parent and child is kind of parallel to what's happening with the parent and the provider, and then the providers to other providers. And so those relationships with community partners are really important. So maybe I'll start with you, Rosalinda, this time. Would you be willing to talk a little bit about the partnerships that are most important in the work that your team does, and maybe a little bit how you've grown and strengthened those partnerships?
Yeah. Well, I guess that I would say overall, our community partnerships are built and sustained through our existing being part of early intervention. And so I think there's a little bit, I think Kiki, at the beginning, you mentioned that this is part of these spotlights is to show different models. And so I'm going to be talking a lot about like, guys, it's really cool to be nestled within early intervention. And I know that there are folks from other early intervention programs here as well today. So yeah, I think some of the relationships with community partners that have been really meaningful to us are relationships with primary care physicians in the area, with DCYF. And this is like thinking about referral partnerships, but also as we're working with families, who are those collateral contacts we're collaborating with. Foster parents are very frequently referral sources. Like once a foster parent has kind of seen one of their kids go through our program, they might come back again and again with new kids, and daycare centers as well. And it's an interesting thing because I think too that Hope Sparks in itself is a bit of a community partner. And I know that sounds odd, but um, many of the families that we end up working with are referred because their child has speech concerns or, isn't walking yet and they're 17 or 18 months. And then we get them into that evaluation space and we're talking with the families and we learn about relationship struggles or about scary events that may have happened in the past. And during that developmentally appropriate evaluation, we're able to kind of recommend or see a need for infant and early childhood mental health. And so the reality is that I would say overall, have plenty of referrals. Our struggle is more that workforce development side of things and like finding providers who are really excited to work with young children. And so, yeah, I think we do kind of quite a lot of work as an organization, our early intervention team, in outreach and in maintaining and building those community partnerships. We have a whole interdisciplinary team of people who meet monthly to talk about outreach and attend different events. And then we also have a really great like system where our family resource coordinators are already collecting information and collateral information that will be really key to the diagnosis process before I ever meet with them. So they're getting records from the pediatricians or from the hospitals that these children have been in, other developmental evaluations they may have had at other agencies, if they have any kind of ASD diagnosis or things like that. We're able to kind of have all of these at our fingertips pretty much from when we begin working with families. So yeah, I think those are the key relationships that we leverage and are lucky enough to have. There are some that we want to build as well, but
Yeah, how about for you at Columbia Wellness?
I would piggyback off of a lot of what she said for our referral sources and relationships. A lot of it's primary care. So we have one of our primary care clinics here, the Child and Adolescent Clinic. We've built really strong relationships with them. And in fact, we had a nurse navigator there for a while too, providing some other assessments that we were able to use with kids coming into our grant program. We have a patient coordinator who is really good about sending referrals and any sort of basic information that's needed as far as any screeners that they have done or concerns that the pediatrician has. And we'll send over things as necessary. Another place is Progress Center, which is early intervention for 0 to 3. We have really strong relationships with them, and when there are other things going on, because they go into the home too and see the different dynamics, so they're able to refer to us as well. And we've gotten childcare centers as well, because we did mental health consultation. So we've built those relationships. So now that the grant is over, it's me maintaining those relationships. We're a small team, but I do my best to maintain all of those relationships with them to continue to know that we're here to support the young children. I think that's kind of where they get lost, right? And so making sure that we maintain those relationships is essential. We also, because we're outpatient children and families, and we have an adult team as well, we often get questions from our adult clinicians. Like, my client came in with their 2-year-old, and man, we need some support. They're overwhelmed. They're not sure what to do, and their kid destroyed my office because they were pulling everything off the shelves, and we're not sure how to help. And so they will also reach out, and a lot of times we can get them in pretty quickly and support them collaboratively with the parents, therapists, and stuff. So that's also another source that we have that's been really helpful.
I love that you both kind of spoke about different ways that the fact that you have multiple kind of like lines of service kind of wraps around into the birth to 5 services. I mean, for Hope Sparks, like you've got the ESA, like occupational therapy, physical therapy might be bringing up mental health concerns. And then for Columbia Wellness, you're working with the parents, and that might be bringing things in. So just, I appreciate how you both are looking for those opportunities and kind of pulling out like, hey, we're already working with this family in a different way. How can we coordinate to bring all of that together? I'm going to ask another off-the-book question, but I'm noticing in our introductions from folks, there's quite a number of pediatricians or folks who work in primary care here today. I'm wondering if either of you could share, and it's okay if you want some time to think about it, is there anything that primary care practices, pediatricians could do that would be really helpful in your process of getting referrals, doing the assessment, working with kiddos? Or things that you've seen and do that have been helpful? Should we come back to this one later?
Hi, Nikki. My name is Catherine, and I'm a pediatrician. I'm sorry, would you state the question again? I wasn't quite, would you restate the question, please?
Sure. So I was asking Megan and Rosalinda if in their experience doing kind of mental health services, is there anything that folks like yourself who are here today could do in that referral, screening, assessment process that would support them? So really exciting to see, you know, primary care folks here in the audience today. So I'm a little bit last minute tailoring the content for you guys.
Excellent. Thank you so much.
I'm not sure if there's anything that they can really do differently. I think for us, we have a really strong patient coordinator that we can work with. And so that's been really helpful for us because we know that the pediatricians are busy. They're usually back to back and don't have a lot of time for coordination. So I'm not sure what we could ask more from them. Sorry about it.
No, that busyness is that's a real challenge. Yeah.
Yeah. I think I feel like those pediatricians that we do have relationships with, it's a beautiful thing because they're thinking about the children and the families from this kind of intersectional way. I mean, there's so many intersections between physical health and mental health. And so I don't think that the pediatricians who we do have relationships with, there's necessarily more to ask. I think it is one of those things where maybe it's interconnection between pediatricians, just reminding each other that early intervention is here, or that, you know, there are mental health services for very young children that exist. And so to be thinking about those, making those referrals more often, just because there's there's never a reason, like, especially in our program, you are always welcome to come in for an evaluation. Families can self-refer, and we may end up saying, we don't have any concerns, but there's no reason not, I guess is what I would say. So tell your pediatrician friends about early intervention and refer them over, because I think that's the thing, is having access to more families through the pediatricians.
And Kate, I see you have your hand up. Do you have a question for the panelists?
Yes. And so I'm Kate Orville. I'm she, her. I'm at the University of Washington with the Medical Home Partnership Project, which is funded by the State Health Department, and also with a large autism training project. And a number of the pediatricians and nurse practitioners here are part of those different networks. And I just want to say that one of the things that's been confusing, because Sophie Mailing, who's also my colleague in here, like, we've tried to share information about the infant, about your project and how to do it. And there's been a lot of confusion about, like, who does what, and, who can do the autism diagnosis using that, and the difference between, like, medical diagnosis for, most kids, you have to be an autism center of excellence if it's Medicaid, and a licensed mental health counselor is not that. And so we've been trying really hard to promote your project and the stuff, and it's been very confusing. And I know some of our colleagues here are also a little confused. And so I don't know. So I guess it's more just like a comment, like, we're trying to promote this, but we get kind of caught up in, the assessment piece and who's doing what. And so anyway, so I came today to try and better understand what you're doing and, share it, but not in a way that just gets people confused, particularly around autism diagnosis. But thank you.
Yeah, thanks for sharing that, Kate. So yeah, just to kind of sum up, what I think I'm hearing is there is some confusion around who can do what, where to send people for what, who's responsible for what. And that is definitely a big concern in our system, where there are definitely a lot of gray areas around scope of practice, but we don't want that to be a barrier to families getting care. So I'm taking that down as potentially something to address at a future webinar. And I think another takeaway for folks could be if there's ways to be clear in your materials in terms of what you can and can't do, or connecting with those local referral partners about, in our area, where do we send kids who we want to maybe assess for autism versus other things, and then how do we make sure those providers are connected to each other, so that if you end up saying, oh, we got here, but we actually meant to get over here, how can we support those warm handoffs so that families don't get dropped in that transfer process? And I also wanted to read out a comment from Katja in the chat that best referrals, the referring knows enough about our services to prepare the families and get their full engagement in the process. And that's, I think, really beautiful too, as well, Katja, that part of that warm handoff, of course, is just how we are and how we interact with the families, but some of it can also be that cognitive piece of, understanding what the family is kind of signing up for, so that you can provide that emotional support of, like, a little bit of what's going on, and then kind of being there for the family as they walk through that process. I'm going to do a little bit of a pivot to another topic, which is around screening tools and observation. This is a big topic for a lot of people who go through the DC 0 to 5 training. I was looking at some of the data actually yesterday about this. Is one of the biggest questions that clinicians have once they go through this training, or it's something that they want more tools and resources for, is what screening and assessment tools should I use for this process? Like, when do I do observation versus a structured instrument versus an interview? And this is not to ask you all to answer all those questions fully, but could you share a little bit more about the screening tools or the observation processes that you use as part of your assessment, and how those are working for you all? And let's start with Megan this time.
I was going to say I might be shorter than Rosalinda in this one. So some of the things that we do for assessments and screening. So when we have families come in for the DC 0 to 5 assessment, we schedule it in 2 sessions at minimum. So I know it can be up to 5, but we schedule it into 1 so we can get information from the parents by themselves. Let's just get some history. Let's get some information about kind of what's going on and why we're here. And the second one is really focused on observing and the relationship piece. We want to make sure that we dedicate a lot of time to that so we can get a good idea of what that looks like and do some observing and also give some instruction on what that might look like. So we use ASQ. We have parents fill out ASQ sometimes with the patient coordinator that we connect with from the hospital or from the clinic. There might be a recent ASQ that we can kind of compare it to or see if historically there have been any milestones that we need to kind of look out for. There has been anything that we should kind of take into consideration when we're assessing. So we use the ASQ, but also we do similarly to like a DPICS assessment in PCIT. So we set up a play session for parents and their child. And so we will let them play freely for a little bit and just kind of do some observing. But then we also at parts will give them prompts. So now I want to see if you can take the lead now and have your child do what you want to do. So we'll kind of prompt them as we do, thank you, Kiki, the DPICS in PCIT, just to observe their free play, but also what does it look like in structured time? And then we gather that information for our relational context axes. So those are really the primarily assessments that we do. We've been looking into what some other assessments might look like and what it might look like to add them in because it's always helpful to be able to gather more information, but that's kind of where we're at right now.
Awesome. Thanks so much. How about you all at Hope Sparks?
Yeah, so our system is really kind of multidisciplinary. We have from the first contact, pretty much, our families are starting an assessment process that's lengthy. And I do think that there's a lot, we ask a lot of families at the beginning of our services in terms of answering questions and going through various meetings and things like that. But our family resources coordinators begin with an ASQ SE at their first intake assessment. So we, the evaluators and providers, have access to that right away when we first meet a family. So we'll look over if there are challenges that are being reported by family members on the ASQ. And then our kids come in for a full developmental evaluation. So when we're thinking about access 5, well, I'm not sure if I'm thinking about the right access right now. When we're thinking about the health, the intersection with the health needs, access 3, thank you, Kiki. We have kind of the background information from medical records, and then we also, for developmental, the developmental access, we have the Battelle. We typically use the Battelle or DAISY. We also, some of our providers, like our motor providers, use other assessments, but we essentially get a really beautiful view of how our kids are doing developmentally in all 5 areas of development. And that includes using the DECA with most of our families to assess for strengths in the social emotional domain. And so that's kind of the baseline for us when we have a new client assigned for mental health services. And then we're thinking about, okay, so how are we going to be assessing the relationship, and how are we going to be kind of gathering added information that we might need based on what we heard from the evaluation, from the ASQ. And so we do then utilize typically at least 3 and up to 5 of those sessions for our intake process, which involves really talking to the family a lot, again, kind of taking them through a lot more background questions, and then also doing some formal assessments of some kind. So It really does depend situation to situation, but some of the assessments that members of our team are trained in are the MIM, which is utilized through TheraPlay. Most of our therapists are trained. That's the Marshak intervention method. But it's a really lovely, kind of similar sounding to the PCIT assessment that you were talking about, where it's mostly structured, but there's a variety of different types of tasks that are looking at different skills within the relationship. We also are trained in the Piccolo, which is a lovely, positive, like strengths-based relationship assessment. Some of our team members are trained in the parent-child feeding scale, feeding interaction scale, which is a lovely assessment, very standardized. And then we also use, the PESI and the life stressor checklist sometimes, especially in more trauma-heavy cases, to gather information around trauma history. And so I think there's a wide kind of toolkit that we have access to. But I also think that we use clinical interview a fair amount when we're thinking about assessing the relationship as well. We really allow our clinicians to have some flexibility about like which of all of this menu of assessments is going to make the most sense within this dyad, within where the family is starting from in terms of their interest and I guess just readiness for change when it comes to mental health treatment. I think some of our families, because we're coming at them from the ESET perspective, they may have not come to us specifically to receive mental health care. And so we spend a long time on relationship building, and that may look like not doing as much like hands-on stuff right away. So it varies a lot. And I think that we definitely utilize those 3 to 5 sessions in a big way. And that has been really meaningful to our ability to do a more developmentally appropriate diagnosis. No shock there, but we are just really grateful for those sessions.
That's awesome. And it's really nice to see that there are different ways to go about this. Sorry, you probably need to take a drink of water. But there's lots of different ways to approach this. Hearing Hope Sparks like, oh, we're using 3 to 5 sessions and we're doing all these different tools, and then thinking about Columbia Wellness as you kind of build out your program and figure out, okay, here's where we started, here's where we want to get to. For either of you, are there any recommendations or tips and tricks that you'd recommend to other providers who are thinking about how to incorporate screening or observation into the assessment process?
Yeah, I think that I don't know, like I can't speak specifically from my personal experience of how to bring various trainings and those types of things. And I think that what we're doing in terms of supporting our clinicians as they're getting trained in this developmentally appropriate assessment is to utilize their like existing clinical skills and clinical judgment. And so it really might be that it's clinical interview or a prompt like, I'd love to just see how you and your child interact. Can you like for 5 to 10 minutes, I'd love to just see you do an activity together, whatever feels natural to you. It's not always really standardized, and I think that's because we understand that we are always only getting a glimpse. Like we are always getting a glimpse into this dyad's functioning. And we understand that sometimes it really makes a lot more sense for that to happen within a more natural feeling activity or engagement. Again, depending on the level of rapport that we have with a family at any given time, especially early on in treatment. So I guess my biggest piece of like what I'm doing when I'm training is really just encouraging clinicians to like tune into the baby, tune into the caregiver, and be present with them. And that is a great place to start. And then we'll load on some trainings and some tools and all of that, but just to start from a baseline of like, let's watch and be curious. So I think that's a really solid place to start. And then there's more from there.
We're always observing from the moment we see them come into the waiting room until we walk them out. And sometimes we walk them out to their car, and we're always observing that interaction. How are they, getting from the waiting room to the office, going to be seen? How, like, what does that dynamic look like? So we're always observing. And so I think sometimes it is more structured, and sometimes it is a more natural process of let's just see how things go. I think it's really ever changing too. I think we went from we need to follow the DC 0 to 5 book from start to finish, and we need to go through these checklists, and we need to make sure we're seeing all of these things, to how to make it more of a natural process. And I think just observing, right from the beginning is a huge part of that. But adding in more as we continue to develop this, I'm sure it's coming.
That's beautiful. Yeah, I love that thing to okay, assessment, sometimes we think of it as this is a specific procedure, like CPT code, and it's a specific period of the episode of care, but also holding in mind that we're kind of constantly observing, assessing, things are going to change pretty quickly for young kiddos, especially. And so even in that treatment period, so to speak, there's still assessment and observation and planning that's happening.
Absolutely. I mean, even when you're trying to have a conversation with the parent and the kid's over here either trying to interrupt, or they're playing with toys, or they could care less about what mom is doing, or, just helping clinicians understand that everything that happens is information.
Yeah, that's beautiful. We did get a question from Louisa, actually, about, and you can just speak to your example, this is not for everybody, but are the clinicians who complete the assessment the same clinicians who are providing treatment if, treatment is warranted? I don't think we actually talked about this in our prep, so I don't remember for either of you. Apologies if we did, but could you share how that kind of works from the assessment to the treatment phases?
So for us, it's not always the case. They don't always stay with the person who completes the assessment. However, all of our clinicians have been trained in DC 0 to 5, and so they're able to continue with that process, so to speak. They're able to understand the assessment, what information is in there, and then know what they're trying to look for moving forward. So they may not stay with the person who completed the assessment, but they are with somebody who has been trained in what to look for and how to gather that information.
Yeah, on our side, the developmental evaluation might be done by other providers in other disciplines. But typically, once a case is assigned to a mental health clinician, that's their provider moving forward. And so the majority of the mental health, and actually all 5 of those, up to 5 of those sessions, is always conducted with the provider that will be their provider moving forward. And I'm glad you brought in, Kiki, a couple of minutes ago, the piece around ongoing assessment and evaluation, because I think that is really important with all clients, but especially with really young clients. I do find that I might make one diagnosis in the beginning, and then later down the road learn of new symptoms, or new symptoms might develop. And so we are thinking about, how and when is it appropriate and necessary to update or change or resolve certain diagnoses based on progress or based on how things are going for the clients. And I will also say that at times we reevaluate, and we kind of launch into more of those assessment sessions based on a change in provider. That does sometimes happen, and we do encourage new providers as they establish work with a family to utilize some of those sessions if they need to do a new assessment, new diagnosis. Or like I recently had a client move from his foster home to live with his dad, and the diagnosis needed to be updated at that time. And so we moved back into an evaluation process. And so we are really flexible with our clinicians and flexible with our families and kids around when do we need to step back and move away from the intervention and back into assessment for a little while to make sure that we're doing, that we're reflecting what's going on at that moment with the family.
Well, thank you both. We are kind of coming to the end of our time together today. So I just want to say thank you to everyone who was here and joined us again. And I want to say so much gratitude to Megan and Rosalinda for being here with us. I am going to drop a link in the chat to a little feedback survey that we have, if you don't mind filling it out. This helps us make sure that these sessions are helpful to you all. And if there's things that we can improve, such as addressing some of the questions around autism diagnosis, definitely have that down as a future topic. So I'm going to put that in the chat. And while you all maybe are filling that out, is there anything, Megan or Rosalinda, that you'd like to close with today? Any bigger picture lessons learned or takeaways from this process that you want to make sure gets out to the world?
Something that comes to my mind is that I was just reflecting on coming into this is I just have so much gratitude. I think, like I said in the beginning, I'm a newer clinician, and I was really passionate about IECMH work before I entered the field of social work. And so I have so much gratitude for the fact that I entered at a time where I get to do my work in a way that feels more aligned with my values. And so getting to utilize a diagnostic framework that meets my clients more where they're at in terms of like developmentally appropriate diagnoses, relationship specific disorder, things like that. And also getting to think about diagnoses within the multi-axial framework, which of course we all know is removed from the DSM and all of that. And so I think as a newer clinician in the field, I just feel a great sense of privilege and like gratitude for all of the work that many of you in this room have been doing, but also many people generally have been doing to make this field more responsive to young children, to the like nuance and specificity that young children bring to the table in mental health.
I second that, and I am so grateful for the relationships that I've really built over the last few years in really being able to learn and understand more in depth about working with the young children and knowing that there's more that we can do. I think for me, one of the biggest things is being able to take the DC 0 to 5 and implement it into what we're doing often. I think sometimes we would, like I said before, turn kids away because they're younger and we're like, well, they don't fit into these boxes, but there are so many things going on. And this gives us another way in which we can support them and support the families. And I am grateful for all of you guys too, because it has allowed me to continue to push a little bit more at my agency where I may not have done that in the past. But Washington and the WAC says developmentally appropriate assessment, this is what it is. And so that also helped to give me some leverage to continue to push this to really serve our young children in the way that they really need to be served. So that's kind of where I would leave it to, is just to keep going. And I really appreciate all the support from you guys.
Well, it has been a huge honor and privilege to get to work with both of you. Thank you, thank you, thank you. And now that we're at noon, I'm going to officially wrap us up. If you are hungry for more content about the DC 0 to 5 and you've been to one of the DC 0 to 5 clinical trainings, I actually have an office hour with one of the DC 0 to 5 trainers that's immediately following this. I'm going to put that link in the chat in case you'd like to join. I'll be there in case you have any further billing or documentation questions. And with all that, I will say thank you. And Amanda, you can pause the record or stop the recording.